Okay, looks like we've got a lot of people into the Zoom, and then also we're streaming on Surgeon. So I will be very happy and proud to introduce Dr. Mahadeven, who's an internationally renowned gastroenterologist and clinical scientist specializing in inflammatory bowel disease, particularly in the areas of pregnancy and drug safety for women undergoing pregnancy with IBD. She currently serves as professor of medicine at UCSF, and I'm proud to say she works very closely with many of my colorectal surgery mentors where I did my general surgery training. So I'm grateful for her time and her expertise here today. As a clinician, Dr. Mahadeven serves as the director of UCSF's Colitis and Crohn's Disease Center, where she specializes in treatment of complex IBD. And specifically, she's a leading global expert on the management of pregnancy and drug safety in patients with IBD. With these clinical interests, she's made significant impact in IBD research, leading trials on pregnancy outcomes and drug safety in women with IBD, as well as the impact of nutritional interventions in the management of IBD. She's authored over 100 publications, and you may have seen that she co-authored our American Society of Colorectal Surgery Clinical Practice Guidelines for the Surgical Management of Ulcerative Colitis. As an innovator, she has led the UCSF GI division in telemedicine and developed a digital health platform called IBD Chat to monitor thousands of IBD patients throughout the time of the COVID-19 pandemic and beyond. And as an educator, Dr. Mahadeven is the program director of the Advanced IBD Fellowship at UCSF. So with that introduction, again, it is a true honor to invite Dr. Mahadeven to tonight's Colorectal Surgery Virtual Education Series. Thank you.
Thank you, Anthony, and it's a pleasure to be here. Well, and thank you for the invitation. So talking about inflammatory bowel disease in 45 minutes is a lot. So I'm going to try to focus on the highlights and particularly areas where GI and colorectal surgery overlap. And we're going to end with a few slides on pregnancy. So the objectives are to talk about what the goals of care are in IBD, management of Crohn's, management of ulcerative colitis, and then talking a little bit about the pregnant patient with inflammatory bowel disease. So you may be seeing a lot more inflammatory bowel disease in your centers, and that's because the global incidence and prevalence is increasing. When I was a GI fellow now 20 years ago, we didn't really hear about IBD patients from India or IBD patients from China, but now these areas all have IBD centers of their own, and the prevalence really is increasing across the world, including in developing countries. And the reasons for that are multifold. We do think that a lot of it has to do with exposure. So antibiotic exposure, having asthma, EBV infection. There was even one study that looked at abuse as a child. So a lot of it has to do with the gut microbiome, the exposures, of course, the genetics. But things that are protective is living with a dog, again, likely due to gut microbiome exposure and hygiene hypothesis, as well as being in a large family. So today with inflammatory bowel disease, how do we approach this patient? It's used to be we would just try to control symptoms, but now we can actually try to heal the lining of the mucosa and change their disease trajectory. So we want to use clearly defined objective markers. We want to clarify between disease activity, which is how they're doing today, and disease severity, which is a course of their disease, when we make our decisions. We want to induce remission rapidly, and we want to be able to describe how they're doing both by patient-reported outcomes as well as objective markers. And the reason for this, again, is to avoid surgery, to reduce the risk of cancer, and to improve the quality of life. So the STRIDE 2 guidelines came out for both Crohn's disease and ulcerative colitis. So the way we think about it is when a patient has active disease, we start them on therapy, we look at their symptomatic response, and we look for normalization of their CRP. These are short-term targets. Then we want to see that their stool calprotectin becomes normal, and for children that they have normal growth. And then finally, long-term targets are endoscopic healing, normalized quality of life, and absence of disability. Things that are being considered now is transmural healing for Crohn's as measured by MRI, and histologic healing for both Crohn's and ulcerative colitis, but we're not quite there yet. When we talk about biomarkers, what you most often see is calprotectin, which is a stool marker of inflammation. It does correlate with endoscopic activity. CRP will often check in hospital, and it may be more elevated in Crohn's disease versus ulcerative colitis, but 20% of people never mount a CRP. But we use less and less sedimentation right now because it's so much less specific. So this is just a study showing that fecal calprotectin correlates with endoscopic activity in ulcerative colitis. I really think of this as a plus minus. So the same patient may send a stool sample twice in the same day, and one will come back at 300 and one will come back in 1,000. What's important is that it's above 150, suggestive of inflammation. This is a survival curve from the infliximab studies that showed that mucosal healing correlated with colectomy rates. So they looked at, you're also probably familiar with the Mayo score, which we try to use in all our endoscopy reports for ulcerative colitis, where 0 is normal, 1 is mild, 2 is moderate, and 3 is severe. And the higher your endoscopic subscore after therapy, with infliximab, the higher your likelihood of having a colectomy. So this is one study that showed an association with healing the mucosa and reducing the chances of surgery. Unfortunately, with all the medications we have, we can't completely heal the mucosa in most patients. And to go beyond healing the mucosa, should we try to heal at a histopathologic level as well? And so there are some patients who look normal endoscopically, have histologic activity, and are symptomatic. Should we change treatment based on that? And what if they're not symptomatic? What can we reduce the risk of colon cancer by healing at a histologic level? And those are all questions that we don't quite have the answer to. Another aspect of our management you may see, particularly in the inpatient setting, is therapeutic drug monitoring. So the biologic therapies that we use, like infliximab, adalimumab, et cetera, have target drug levels at trough right before the next dose that can predict if a patient is doing well or not, or if they're rejecting the drug by developing anti-drug antibodies. So for example, in the PAN study, if you had a infliximab level less than 7 micrograms per ml at week 14, then you're less likely to have a good response. So you would try to increase therapy at that point. Another way we do it is when you have somebody with severe ulcerative colitis in the hospital who has hypoalbuminemia. So in that case, they're going to lose a lot of antibody in their stool. In those patients, you may give them a big bolus of infliximab, and they're great for a few days, and then they get worse again, and you check their levels, and they're no longer detectable. So levels help us, and our target level at baseline is somewhere between 7 to 10 micrograms per ml. So those are just some of the diagnostic tests you may be seeing. Let's talk about managing Crohn's disease. So if you think of the 123 years between when Wilkes first described ulcerative colitis in 1875 and infliximab came out for Crohn's in 1998, there was just a single FDA-approved treatment for Crohn's disease in that time point, and that was infliximab. But after that, you can see there's been an explosion of biologic and small bowel therapies over the last 24 years, with the latest therapy just approved in June of this year called risankizumab. And we're going to go through this alphabet soup. So when we look at medications for ulcerative colitis, let's look through these therapies and see where we would use them. 5-ASAs are not FDA approved for ulcerative colitis. Sometimes we may use sulfasalazine for mild colonic disease, but in general, you shouldn't be using 5-ASAs for Crohn's disease. They're not effective. Mesalamine is FDA approved for ulcerative colitis from mild to moderate disease. Steroids are not FDA approved, but of course we use them all the time as a bridging therapy. Thiopurines and methotrexate are not FDA approved. At this point in the United States, we're mostly using them as concomitant therapy with a biologic to prevent rejection or loss of response. When you look at the anti-TNFs for Crohn's disease, there's infliximab, adalimumab, and certolizumab. For ulcerative colitis, there's infliximab, adalimumab, and golimumab. Infliximab, of course, is Remicade. Adalimumab is Humira. The anti-integrins, so these are therapies that block white cell migration to the gut. Vedolizumab and natalizumab for Crohn's disease. We don't really use natalizumab anymore because it is associated with a brain infection called PML. and then vedolizumab or Entyvio for ulcerative colitis. A newer class are the anti-IL-23s. Ustekinumab for both Crohn's and UC is known as Stelara. It's the anti-IL-12/23. And risankizumab just came out, is a isolated IL-23 agent. Both vedolizumab, ustekinumab, and risankizumab have excellent safety profiles with no increased risk of infection, no increased risk of cancer, which is different from the anti-TNFs, which do have an increased risk of infection, skin cancer, and a 1 in 1,000 risk of lymphoma. Another new class are the JAK inhibitors. These are pills, while the biologics are IV and sub-Q. There's upadacitinib, which is off-label for Crohn's disease and FDA approved for ulcerative colitis. Tofacitinib, FDA approved for ulcerative colitis. These are highly effective agents. They have a similar safety profile to the anti-TNFs, but they also have an increased risk of VTE and MACE, particularly in older patients. And another new class is ozanimod for ulcerative colitis. So a lot of options that we can use. And so let's take a step back and say, what is moderate to severe Crohn's disease? How do we define it? So our high-risk patients with Crohn's have larger deep ulcers, fistulas, prior surgeries, extensive ileal involvement, presence of stoma, and prior exposure to biologics. All of those make them more high risk, where we would be more aggressive with their care. So the AGA came out with guidelines, and I'm not going to go through all of these, but the big change in how we practice now compared to how we practiced even 10 years ago is we really don't recommend the use of thiopurines as first-line therapy. We go straight to a biologic if they have moderate to severe disease. So for Crohn's disease, TNFs, ustekinumab, and risankizumab are recommended. Vedolizumab is not as good for Crohn's as it is for ulcerative colitis, so it's a conditional recommendation. If they're naive, then the same therapies can be used, but if they have a failure of infliximab, it's recommended you go to ustekinumab as opposed to any of the others. Steroids are really for bridging. Mesalamines should not be used. So we'll go through these in our case. And for the guidelines, the thumbs are recommend in favor, strongly, suggest, no recommendation, suggest against, or recommend against. So let's think about this patient. This is a 25-year-old woman with a new diagnosis of moderate to severe ileal Crohn's disease with abdominal pain, anemia, but no stricture noted. She has no other medical problems, no plans for pregnancy in the next 3 years. So would you recommend medical or surgical therapy? And she wants to know if there's a pill she can use. So I'll ask you all as surgeons, would you offer this woman a resection? She has moderate to severe ileal disease, say 15 centimeters, no stricture. And you could say, okay, well, usually in this setting, we recommend therapy. So she wants to use a pill. Please don't use 5-ASAs for Crohn's disease. So in the 80s, people would get Pentasa, but there's the studies were negative. It doesn't work. It's a waste of money. So the AGA recommends against the use of 5-ASAs for Crohn's disease strongly. And she's sick, so she needs therapy. You can use steroids over no treatment to induce remission, but you shouldn't be using steroids for maintenance of remission. So this should really be like an 8-week course, 40 milligrams a day, reduced by 5 milligrams per week, off steroids in 8 weeks. And if you need steroids for Crohn's disease, you should have a steroid-sparing therapy that you're going to start. Now, thiopurines are not effective for induction, so they're not recommended for induction, but if the disease is quiescent, you can use it to maintain remission because there is some data for that. So if you decide, for example, this patient has no insurance, or insurance won't cover a biologic, you start her on corticosteroids, she responds, and now she has quiescent disease, you can start a thiopurine as a steroid-sparing agent and for maintenance. This is not ideal, but it can be done. Methotrexate, same thing. You can use it to maintain remission. There was a randomized trial, but again, we have much more powerful agents that are more effective with lower safety, with better safety profiles, so we shouldn't be using these. So what are our first-line therapies? The AGA recommends early introduction of a biologic agent alone or in combination with an immunomodulator. And recommends biologic monotherapy over using a thiopurine alone. So we've gone through some stages where everybody had to get combination therapy with the biologic or immunomodulator, but that really doesn't seem to be the case anymore, particularly for the newer ones, ustekinumab and vedolizumab, where you don't need an immunomodulator. For infliximab, you probably do, because it does have more antibody formation. So in this patient, you could use a TNF. That's strongly recommended. There's excellent data showing benefit. You could use ustekinumab or risankizumab. Again, great data showing that these patients will respond. You could use vedolizumab, though the data for Crohn's disease for vedolizumab is not as good as the other agents and is not as good as their data for ulcerative colitis. So for this lady, I would think about infliximab, adalimumab, or ustekinumab. Since she's never been on a biologic, those would be the agents we think about. And then this is just a comparative effectiveness study showing infliximab was superior to all of these, particularly certolizumab. All of these agents were better than certolizumab, and then ustekinumab was also better than certolizumab. So we don't use a lot of Cimzia or certolizumab. Infliximab, adalimumab, ustekinumab, risankizumab in this patient. This is just a study showing ustekinumab and adalimumab were the same for induction and maintenance of remission in moderate to severe Crohn's disease. This was a head-to-head trial, so you could use either one. But if you were a patient, ustekinumab is an injection every 8 weeks versus every 2 weeks for adalimumab, and has a much better safety profile. Now, what about surgery? I wonder how many of you would have offered this patient surgery. In Europe, they did a randomized trial where they took patients exactly like this one with moderate to severe ileal disease alone, with no stricture, and randomized them to infliximab versus a resection with a median follow-up of 69 months. And in the LAP ileocolonic resection group, only 26% required an anti-TNF, 48% were given prophylactic immunomodulators, and no patients required a second operation. In the biologic group, 48% required a Crohn's related surgery, and 52% maintained anti-TNF therapy. At 1 year and at 5 years, going straight to surgery had a better quality of life and was cheaper as well. Now, they didn't do colonoscopy on these patients to look for recurrence. So this was based on like a Crohn's disease activity index and these outlines you have here, but it's still a very provocative study. And now when I have a patient with limited ileal disease, I do bring up the LYRIC trial and whether this would be an option for them. So the patient started on infliximab 5 milligrams per kilogram monotherapy. She felt better after 3 doses, and unfortunately at 6 months did not come back for follow-up. This is a problem because the biologics, you have to give them on a regular basis for the body to tolerate them. Otherwise, they are seen as foreign and the body makes anti-drug antibodies and destroys whatever infliximab or other agent you give. So now she comes back a year later, she has a significant stricture and she has pre-stenotic dilation. So usually in someone with pre-stenotic dilation, I feel they are almost certainly going to need surgery. She also has a 3-centimeter abscess and a new perianal fistula. So what would you do now? Medical therapy versus surgical therapy? Do you need to hold the biologics before or after surgery? And I know this is a big deal. And so I have some slides on that as well. So this is a patient who's already been on infliximab. She's not a primary non-responder because she actually responded to the infliximab, she just stopped it. So here you could use ustekinumab or vedolizumab, though vedolizumab is less likely to be effective. So ustekinumab is an option. She's actually a lost responder, and so you could also use adalimumab here. Or ustekinumab over no treatment. But what about the abscess? So, sorry, when I talk a lot, I cough. So the initial management, IV antibiotics, supportive, reduce steroids, hold immunosuppressive agents, nutritional support, and drainage. But the cutoff is 6 centimeters. So if it's greater than 6 centimeters, she would go to surgery and consider diverting ileostomy versus primary anastomosis, and that has to do with the abscess is drained and what it looks like. But hers is less than 6 centimeters, so you could use antibiotics, interventional radiology drain, and biologics, and then follow her and see how she did. For her perianal disease, you would do an exam under anesthesia, but if the perianal disease doesn't heal, there are some great new options that we do in collaboration with our surgeons. A lot of this data is also from Cleveland Clinic and Mayo Clinic, but mesenchymal stem cells for complex perianal Crohn's. And what this is approved in the European Union, but is undergoing trials here. And essentially the surgeon goes in, cleans out the fistula tract and puts in this plug of mesenchymal stem cells. And there's been really excellent healing in patients who have not healed with medical therapy alone. So the other big question, one of the biggest fights we probably have, because colorectal surgery and GI work very closely together. And for me to be successful as a gastroenterologist in inflammatory bowel disease, I need to have a very good relationship with my colorectal surgeons, which I do. And we communicate very well. But if you look at the two groups as a whole, the one question that is usually the bone of contention is whether the therapies we use lead to more infections. And every time a new drug comes out, there's a study that comes out of Cleveland Clinic and Mayo Clinic that says it leads to more complications. And then 5 years later, they reverse that. And so we've seen that pattern several times now, infliximab, vedolizumab, ustekinumab. So the Puccini trial was a prospective trial done at 17 centers, 955 patients underwent surgery, and there 40% had pre-op TNF inhibitors. And they found that TNF inhibitors within 12 weeks was not associated with post-operative infections. And so the preoperative use of an anti-TNF should not affect surgical decisions in IBD. This was a study by Ben Cohen at Mount Sinai. You could say, okay, well, he's a gastroenterologist, but here are two studies from the Cleveland Clinic. The first one was published by Shah in the Journal of Crohn's Colitis, and they looked at Crohn's disease with ileoclonic resection from 2009 to 2019. 800 patients at the Cleveland Clinic Foundation, 31% anti-TNF, and then about 6% veto and ustekinumab. And they found that preoperative albumin less than 3.5 was associated with intra-abdominal septic complications, but there was no association with biologic use. And then this most recent one, I couldn't find the paper. This was on the Cleveland Clinic website, but it just came out, the American College of Surgeons NSQIP IBD. And this was led by, this particular part was read by Stephen Holobar, looking at 14 institutions, 4,500 patients, 50% exposed to biologics, no association with preoperative biologic exposure and postoperative infections, surgical site infections, or anastomotic leaks. And Dr. Holobar says preoperative biologic exposure alone shouldn't require an ileostomy in these patients. So I hope now with these studies, we can all agree that you shouldn't, if you have a patient with Crohn's disease or ulcerative colitis who needs surgery, surgery shouldn't be delayed for them to wash out their biologics. We hear about this all the time. We're like, okay, well, just put them on steroids and stop their biologics, and we'll do the surgery in 4 weeks. Of course, during that time, the patient's going to be sicker, and malnutrition and steroid use are much bigger predictors of adverse outcomes. So I think now we're all on the same page with the biologics. So going back to our patient, she gets a drain from IR, antibiotics, and is seen by surgery. She gets an exam under anesthesia with ceton placement. She wants to avoid surgery for now. She says she doesn't have obstructive symptoms, agrees to start ustekinumab. Do we do this as combination therapy or monotherapy? And so this might be a little bit inside baseball for non-GIs, but the only time we use combination therapy is with infliximab and maybe adalimumab, where there's some recommendation. I will often use monotherapy, check their drug levels, and just keep them on the biologics to reduce risk of infection. But for vedolizumab and ustekinumab, there is no indication to use combination therapy, so I wouldn't for her. Okay. So moving along to ulcerative colitis, let's talk about a second patient. This is a 28-year-old woman who presents with 3 to 4 loose stools per day with urgency and blood. Stool studies are negative. She has mild anemia and fatigue and undergoes a colonoscopy that shows pancolitis. Pathology confirms chronic active colitis, and you start her on mesalamine. She improves, no further symptoms. So I just want you to remember, this is maybe what what is more common, but 10% of ulcerative colitis patients present with severe disease and require a colectomy in their first year of diagnosis. So I want to emphasize that it's disease severity and not how long they've had it that determines their need for surgery. So for mild ulcerative colitis, mesalamine is great. So she returns now 2 years later with pan-ulcerative colitis on mesalamine, but she doesn't always take it. She's been off medications for 6 months and had a flare. She restarted mesalamine 4 weeks ago with no benefit. Now she's having 6 to 8 bloody bowel movements a day with elevated sed rate and CRP. Labs confirm inflammation, but there's no C. difficile. We always check that. And FlexSig shows Mayo 2 to 3 disease. So what is next for her? So when we talk about UC activity, we look at mild, moderate, severe, and fulminant. Fulminant is what you see in the hospital, more than 10 stools per day with bleeding, toxicity, abdominal tenderness, even colonic dilation on x-ray. She's in the severe category with more than 6 stools per day with some elevated sed rate and other symptoms. And then you want to look at whether she's low risk, limited anatomic extent, mild disease. No, she has pancolitis, so she has extensive colitis, and she has moderate to severe disease. She has a high CRP. So this is somebody that we're concerned about. We will use the Mayo score to talk about disease activity. And so she's a Mayo 2 to 3, she's moderate to severe here. So again, suggesting that this is someone for concern. So she was started on 40 of prednisone with a taper, and we sent all the blood tests in preparation for a biologic. She was started on infliximab and methotrexate, so combination therapy. By her second infusion, she was feeling better and tapering off the prednisone. She was able to taper off prednisone in 8 weeks and had a week 14 infliximab trough level of 12. Remember, we need to be greater than 7 at this point, so it looks good. FlexSig is 0, Mayo 0 at week 14, and she continues her therapy. She did well for a year, but developed sinusitis and then a C. difficile infection following a course of antibiotics. And now she has a severe flare despite being treated with vancomycin. Her infliximab levels are great, so it's not an issue of not enough drugs, but FlexSig shows moderate disease. So here, what would you do? So she's not naive. She is a prior infliximab failure. So here we could use ustekinumab or the newer JAK inhibitors, tofacitinib or upadacitinib. Adalimumab really does not have a role in ulcerative colitis. It's not very effective. Vedolizumab is effective as your first-line biologic, but not like someone in her who's failed TNF and is doing poorly. So tofacitinib showed excellent efficacy, including in anti-TNF exposed patients. However, for tofacitinib, there is a warning that came out from the FDA in 2021, and this was based on the oral surveillance study done in rheumatoid arthritis. They took patients with rheumatoid arthritis over the age of 50 with at least one cardiac risk factor, and they found that thrombosis, including pulmonary embolism, DVT, and arterial thrombosis, occurred in patients treated with tofacitinib and other JAK inhibitors at a higher rate than those treated with infliximab. So it has this warning. However, we really haven't seen an increase in cardiac or vascular events in our ulcerative colitis patients who tend to be younger. We use this agent, but the FDA does not allow us to use tofacitinib or upadacitinib unless they failed an anti-TNF. So this patient would qualify, and these are very effective agents. Remember that any patient with ulcerative colitis or Crohn's disease has an increased risk for VTE, and when they are admitted to the hospital, they need to be on VTE prophylaxis. That should be part of your hospital guidelines for patients with IBD. It's malpractice not to give these patients VTE. Even if they're having multiple bloody bowel movements a day, the subcutaneous or the low molecular weight heparin does not increase bleeding, and they need to be on it. So important to remember. A newer class are the S1P modulators. These block lymph white cells leaving the lymph nodes. And the one that we have is called ozanimod, which this is really more for moderate ulcerative colitis in people who have not been on a TNF yet. Someone like her who's more severe, this wouldn't be an effective agent. I didn't talk about upadacitinib, but it's in the same family as tofacitinib and has excellent, truly excellent response in these severe patients who failed a TNF. And so UPA or TOFA would be a good option for her. So when we take a step back and say, okay, we have TNF agents, highly effective first or second line therapy for ulcerative colitis and Crohn's disease, the box warning, serious infection, 1 in 1,000 risk of lymphoma, rare lupus-like syndrome. Ustekinumab and risankizumab have excellent safety profiles with no boxed warnings. Vedolizumab really only works in the gut, no black box warning. Upadacitinib and tofacitinib, along with infliximab, are the most effective agents we have. There is a black box warning for serious infections, mortality, malignancy, and thrombosis. Ozanimod, no black box warning, but you do need to ramp it up because it can cause some bradycardia. Another thing we think about when we look at these agents is what else can it help? So if you have a patient with Crohn's disease who has a fistula, the best options are the TNF inhibitors because they work the best for fistulas. Maybe the JAK inhibitors, but they're not approved for Crohn's yet. If they have skin infections, ustekinumab, the anti-IL-23s, the JAK inhibitors, and the TNFs can be helpful. Vedolizumab only works in the gut, so it's not so helpful for people with joint pain, which is best treated with a TNF or upadacitinib. So we think about all the different manifestations as well when they pick an agent. So she opted to stop all therapy and follow with the functional medicine doc. She presents 6 months later, admitted to the hospital with a severe flare, 15 to 20 bloody minutes a day. So now she's in the fulminant category. Minimal response to intravenous methylprednisolone. Stool studies are negative. Her albumin is 2. Flexig with Mayo 3 disease with deep ulcers. When this patient comes into the hospital, we call our colorectal surgical colleagues the first day as part of our algorithm. And then we say, what are her options? Could you go back to infliximab? That's possible. We can give her IV steroids for induction. We can retry infliximab because she stopped it, not because it didn't work, but oh no, I'm sorry. She did stop it because it didn't work because she went on the antibiotic. So that would not be an option for her. If she had just stopped it on her own, then perhaps you could have gone back and retried it. Cyclosporin, you can, or tacrolimus are induction agents, like the University of Chicago will often use these, and Mount Sinai and Cedars-Sinai as well as an induction agent, and then maybe you can transition them to an ustekinumab or vedolizumab. And then there are centers like University of Michigan looking at tofacitinib and upadacitinib as salvage agents for these inpatients, and we certainly have used it inpatient as well to try to turn these patients around. So she was trialed on tofacitinib 15 milligrams BID in hospital. There's no response by day 7, and she underwent a 3-stage colectomy and J-pouch. Okay, and the final slides I'm going to go through are IBD and pregnancy. So my area of expertise is pregnancy and inflammatory bowel disease. Women with inflammatory bowel disease have higher rates of miscarriage, preterm birth, low birth weight, complications of labor and delivery. If they have active disease, those risks can be 3 times higher, and it's harder for them to conceive. As you probably know, when you do surgery in the pelvis, for example, a proctectomy or a colectomy with J-pouch, you are going to reduce their ability to conceive on their own. There is a thought that with the new laparoscopic approaches that may be minimized because there's less adhesions, but we don't have enough good data to really say that for sure. But this taking care of a pregnant woman with IBD is a multidisciplinary approach. Women with IBD have, because of these increased complications, they should be followed by a maternal fetal medicine specialist. So not just an OB, but a high-risk OB as well. Of course, they're gastroenterologists, and depending on their surgical history, stoma, J-pouch, colorectal surgeon will be involved. Often our patients come in for a planned C-section or planned induction, and the colorectal surgeon's on standby because of their surgical history. A nutritionist, a psychologist, a lactation consultant, a pediatrician. We need everybody to be on the same page. I always like to say that no one gets more unsolicited advice than a pregnant woman. So it's important that she is armed with the knowledge to know what to do for her disease, what medicines to continue before she gets advice from her family and random people at the grocery store. The medications that are contraindicated in pregnancy are methotrexate and thalidomide. These both cause miscarriage and birth defects, so we never want to use those. They need to be off of them at least 3 months before considering pregnancy. Mesalamine is fine, but mesalamine with dibutyl phthalate in the coating, that used to be Azicol, though now DBP has been removed, but this was associated with male urogenital birth defects. Now mesalamine does not have that, so you can continue. Steroids are associated with an increase in complications, and most likely related to disease activity. The ozanimod, tofacitinib, upadacitinib are oral agents. So when you take them, they cross the placenta in the first trimester when the baby's organs are forming. And so that's how they can be associated with birth defects. And we do see birth defects in animal models. Cannabis, some patients with IBD use cannabis to treat their disease or its symptoms. This is not recommended in pregnancy. Medicines you can continue: mesalamine, azathioprine 6-MP, anti-TNF agents, ustekinumab, risankizumab, vedolizumab, and then low-dose aspirin is given to these women to reduce the chances of preeclampsia. The biologics can be continued because they're antibodies, and antibodies don't cross the placenta very much in the first trimester. However, beginning around week 14, the placenta develops a receptor called the FcRn, and that will grab the Fc portion of the antibody and pull it across the placenta to the baby. That's how mom transfers her immunity to the baby. And since these are biologics, they will also transfer. 80% of that transfer occurs in the 3rd trimester. So baby can be born with higher levels of biologic than the mother, and these can be there for 6 months. However, we've shown that this is not associated with an increased risk of infection. They should not get live vaccine in the first 6 months, which in the US is just rotavirus, but all other vaccines can and should be given on schedule. And so this was a study called PIANO, which is Pregnancy and Inflammatory Bowel Disease and Neonatal Outcomes. This study started in 2000 and is ongoing. We look at pregnant women with IBD across the country. We have about 2,000 enrolled, and we look at their outcomes. So there are 1,490 women, 379 on no biologics or immunomodulators, 242 on immunomodulators, 642 on a biologic, and 227 on both. There is no increase in birth defects, spontaneous abortion, preterm birth, low birth weight, or infections based on biologic or thiopurine use. If they had preterm birth, they had a higher rate of infection. If they had active disease, they had a higher rate of miscarriage, and there is no impact on developmental milestones of the medications they were on. When I first started, some gastroenterologists will say, well, we're going to stop all their IBD medications, and if we need to, we'll put them on steroids. So we also showed in PIANO in 432 steroid-exposed moms that being on steroids in pregnancy was associated with a higher rate of preterm birth, low birth weight, and NICU admission. There is no increase in birth defects unless they used it in the first trimester, where there was an increase in birth defects. So of all the medicines we use, steroids have the highest impact, negative impact on pregnancy, some of it having to do with disease activity. So one thing that might make you shudder as a colorectal surgeon is if you get called for a pregnant woman who is having severe colitis and may need a colectomy during her pregnancy. So these patients, I've had about 2 or 3 of these in the last 3 years at UCSF. This was a study that came out of the Journal of Crohn's Colitis. And it looked at 44 patients, I believe, in Spain between 1998 through 2021. 70% of these patients had C-sections and 4 had spontaneous abortion of stillbirth. So 44 patients who had surgery during pregnancy. The majority were in the second trimester with 55%. And that, of course, is the ideal time to do surgery, but you have to do it based on the patient need and not her trimester. The indications included obstruction, abscess, severe colitis, severe Crohn's, perianal disease, etc. 77% were urgent. There are 11% had fetal complications, including the 2 stillbirths, and there were 4 pregnancy losses. Now, the thing that I thought, there was also a hemoperitoneum in the mother, and 27% had post-surgical complications, including abdominal abscesses. This study, called the PAPOOSE study, looked at patients with stomas. And so patients with stomas can be very challenging. First of all, they've had a lot of surgery in their abdomen. This is from the UK, looked at 82 pregnancies, 88% had an ileostomy, and they found 1 miscarriage, 1 stillbirth, 80 live births. But what was concerning was that 73% had C-sections, and 3 of those had bladder injury. 2 of them required significant adhesions requiring adhesiolysis. 24% had stoma-related complications, and postpartum hemorrhage occurred in 7.5%, requiring surgery. So I think the biggest risk here was to the mom having a pregnancy with a stoma, and they really need to be in a center of excellence with good colorectal surgery backup. This isn't somebody who should be delivering her baby in her bathtub at home or in a remote area without adequate ICU support and surgical backup. One other thing, you never, ever, ever need to oversew a stoma for a delivery. And I never thought I'd have to say this, except one of my patients went for C-section, and the obstetrician oversewed her stoma to prevent seepage instead of just putting a gauze on it. And she has had severe Crohn's in that area ever since. So no need to oversew a stoma for a C-section. Okay, I think I am right on time. I am happy to take any questions that you may have.
Well, thank you so much, Dr. Mahadeven. That was a real excellent tour de force on the medications and sort of the interplay between how we work together as GI and colorectal surgery. We'll go through, if there's any questions right now, you can put them on the chat or through the chat from Surgeon. While people are starting to think of their questions, I actually have a couple, or one thing that has sort of come up a couple times this month: medically refractory UC, and then deciding to do a colectomy. Mm-hmm. For a lot of patients, you know, infliximab has been around for a long time. People have been on it. There's some newer medications now. If a patient has been on Remicade in the past, maybe they've been on it, they come in with very acute ulcerative colitis, but they have not tried one of the newer agents. Mm-hmm. Is there a way to sort of temporize them with high dose IV steroids to bridge them, to get them onto that biologic and see how that they do? Is that something that you would try in somebody who has never been exposed to the newer biologic agents?
Yeah. Absolutely. I think that it depends on how sick they are. So you're saying somebody comes into the hospital with severe ulcerative colitis flare despite being on infliximab, Remicade. So our protocol is that, they get started on IV steroids, you rule them out for C. diff, you start them on a low molecular weight heparin. If by day 3, they don't really respond to IV steroids, that's a bad sign. But we have been using JAK inhibitors in-house, upadacitinib or tofacitinib, which are known as Rinvoq and Xeljanz. And so that can be effective in people who fail infliximab. And there are small trials at institutions, and we use it at our institution for these patients to see if we can salvage them. even if
Right.
they don't respond to steroids. If they respond to steroids and go home, then we have more things to offer. But in hospital, it's usually the JAK inhibitors.
Great. That's a good thing to keep in mind in the toolbox. I have not seen that used so far. Okay, so a couple questions on the chat here by one of our leadership committee members, Dr. Susie Hill. She says, I was surprised by the clinical practice guideline, UC guidelines that talk about infliximab versus cyclosporin. Is there anything that makes you your reach for the latter, for the cyclosporin? I feel like I've anecdotally only seen infliximab for patients, but if they don't respond to high dose IV steroids initially, I think that maybe you answered a little bit of that in the last question, but go ahead.
So is a question is whether, so cyclosporin is not part of the, we don't use cyclosporin. Most hospitals don't use cyclosporin. There are some hospitals that, so Mount Sinai, University of Chicago, and Cedars-Sinai are the only hospitals I think that still will use IV cyclosporin as an induction agent, or tacrolimus. They're both IL-2 inhibitors as a induction agent to get people out of the hospital. And but it's not in the guidelines. We don't use it. So if you fail infliximab, you don't want to go to cyclosporin. That actually is contraindicated. There have been some deaths at Mount Sinai when that was done because it's a huge amount of immunosuppression. I'd rather go to a JAK inhibitor.
Okay, great. Another question from one of our other leadership committee members, Dr. Matt Bobel. This was an incredible talk. We'll definitely need to watch, listen again. I'd love to hear more about the framework or algorithm that you use at UCSF when patients are first referred to surgery. What are the common trigger points?
So, it's interesting because as you know, the residents turnover, the hospitalists turnover, our fellows turnover. So that's why we created in EPIC a checklist, and we put it into every note, and we sort of trained the fellows on this. And we showed Sarah Lewin in our group and Ryan McConnell showed that it actually reduced hospitalization by a day. If people stuck to this. So what happens is a patient comes in with severe ulcerative colitis on day one, they get C. diff sent, they get a PPD placed, they get their hepatitis serology sent in anticipation of a biologic. And often the colorectal surgery consult will be called on day one, and our surgeons are fine with that. They know we don't admit people unnecessarily. So somebody admitted with severe UC has a 50% chance of getting a colectomy on that admission. And so the surgeons are happy to, they're part of this decision-making process, happy to see them. So we also do within the first day or two a flexible sigmoidoscopy. And so IV steroids, sub-Q heparin, send the labs in anticipation of a biologic, call the surgeon, do a flex sig, stage the disease. And then at that point, by the blood tests and PPD are done in 48 to 72 hours. And so on day 3, you can start your therapy. So if they completely respond to IV steroids, we may transition them to oral prednisone and send them out of the hospital to get their Remicade or whatever we're starting, because the hospital does not get paid for the biologic. So some hospitals don't allow you to use it. Ours do, but in the interest of good stewardship, if they're doing great, we send them to outpatient. If they're not doing well on day 3, we start the infliximab or whatever it is that we're starting. And then every day we check CBC, albumin, CRP, and we want this to see the CRP come down. We also order an imaging study if they haven't had one. The surgeons want to know if they have small bowel disease, but everyone that comes in the hospital is pretty much a 3-stage operation.
Great. One of the
and also one very important thing, no narcotics. That's really, really important. Patients should be allowed to eat. They go on a low residue diet. We never make them NPO, so they eat, but no narcotics. And that's something we have to really initially had to really fight with medicine because they'd always put our patients on Dilaudid, but that dilates the bowel. It slows down the number of bowel movements, so you can't use your usual scores to determine if they're getting better or not. And actually with the dilation of bowel, they get more pain and need more narcotics. And so we don't use narcotics. That's very important.
Super important point that we'll definitely have to think about every time we see one of these patients. One of the current colorectal fellows, LK Lau, asks, in mild UC, do you recommend biologics first over 5-ASA? And then in Crohn's, do you go straight to biologics?
Yeah, so great question. Mild ulcerative colitis, mild to moderate ulcerative colitis, we will do a trial of mesalamine. It is effective in ulcerative colitis, 2.4 grams versus 4.8 grams, depends on how severe they are. But mild to moderate ulcerative colitis, yes, we'll use a 5-ASA and then go on to the biologic. For Crohn's disease, the 5-ASAs don't work. So if they have really mild ileal disease, the guidelines are really, you leave them alone. But if they're symptomatic, then you would move on to a biologic.
Great. Clay Merritt asks about a case scenario, a female patient with complex perianal fistulous disease, never been on a TNF inhibitor, but currently on vedolizumab. Would you recommend switching to a TNF inhibitor for people with a complex perianal disease?
Oh yeah, vedolizumab does nothing for perianal fistulizing disease, especially complex. So if the fistula is very mild and you can do an EUA and really heal the bowel, then maybe they have a chance of getting better. But someone with complex fistulizing disease, it really has to be the anti-TNFs. In particular, I would use infliximab in someone like that. Make sure that they're properly drained. So an EUA plus an MR or endoscopic ultrasound if appropriate, but definitely need 2 modalities if it's complex. The JAK inhibitors may show some benefit for fistulizing disease, so that's something to think about as well as we get more data. But I would use a TNF in someone with complex perianal disease.
Great. One of the current colorectal fellows, Dr. Shrey Modi, asked, thank you, Dr. Mahadeven. The last study of the stoma, the patient with the stoma, the pregnant woman with stoma, was the disease quiescent at the time of pregnancy, or were there poor outcomes were due to disease activity instead of actually having the stoma? Like, in other words, was the Crohn's disease very bad at that time?
No, for the majority of patients had quiescent disease. I think it was more like it, and this was in the UK, so it's unclear if these were all patients at a center in the community, but it was, you know, it was surgical complications from the C-sections, et cetera, due to all the adhesions. It wasn't really active disease.
And do you do anything, the follow-up question to Ed is, do you do anything differently for nutrition for pregnant patients in terms of optimizing pregnant patients, like TPN, for instance? Is that something that you're
So TPN only if they can't use their gut. We always try to use their gut, but nutrition is very important. If they don't have appropriate maternal weight gain, they will do worse. So somebody who's had ileal resection or a significant amount of small bowel resection, or who's underweight, we do have them follow with our nutritionist to make sure they gain their 20 to 25 pounds that's recommended.
Great. The last question I have here is from Dr. Siva Dantu. Awesome talk. For Crohn's with abscess, the less than 6 centimeter cutoff for starting medical therapy is assuming they can get drained, or will you start after only antibiotic therapy as well?
We always try to drain if we can, always, but sometimes you may have something that IR says we can't reach that. In that case, we will cover them with antibiotics, and after a couple of weeks, start a biologic and still continue the antibiotics and monitor their CT, because there's no other way. If you don't treat the inflammation, they're not going to get better, and you can't actually get in there and drain the smaller fistula, like a 1 centimeter, 1.5 centimeter abscess.
Great. Well, I think that's all the questions. We really appreciate your time and for enlightening us surgeons with the gastroenterologist side of things. It's a really important interplay and communication between both fields. We really, really appreciate it.
Thank you for the invitation. Have a good night.
Take care.
Bye.